Good afternoon, everyone. Welcome to today's SVS VQI Updates and Registry Revision webinar. My name is Jennifer Correa. I'm the Marketing Manager at the SVS PSO. I'm joined today by our presenters, Katie Sullivan, SVS PSO Senior Statistician, and Carolyn Morgan, SVS PSO Director of Clinical Operations. Before I turn things over to Carolyn and Katie, I do just want to go over a few brief housekeeping items. We will be keeping all lines muted throughout today's presentation, but we do encourage you to type any questions you may have in the Zoom Q&A box. This will allow us the opportunity to answer questions as time allows at the end of this presentation. In the event that we are not able to answer your question live during this session, we will reach out to you via email following the webinar. And with that, I will turn things over to you, Katie.
All right, thank you, Jen. So today I wanted to give an update on a new type of report that has just gone out. So last week, physicians should have received a report specific to their individual cases. So these reports include physician level results with benchmarks for their center and also VQI overall. So in order to appear in these reports, I did want to note that centers must have at least 3 physicians, and then physicians must have at least 10 cases in order to appear in the comparative figures that other physicians would see to avoid any accidental identification. And then within the report, physicians can see their individual results and then also access detailed case information at the end of the report in the drill down appendix, so they can see their individual cases and drill into specific cases that stand out. And then these initial reports for the spring started out with a small selection of about 4 of our regional report metrics that will be expanded to include more registries and more reporting metrics in future cycles based on feedback from this initial run of reports. So then I just wanted to go through a few examples of what these reports look like. So I also want to mention that hospital managers at centers where a physician is receiving a report did receive a sample report with demo data, just so that you could see how the format looks and help answer any questions that physicians at your center might have. So that's what this looks like. It'll have that little sample report watermark over it. And then this is a snapshot of that sample report here, where you can see the physician results under the Your Results column, and then the center and VQI overall results. And then there'll also be a year-over-year chart. So for the spring, we looked at the past 4 years, so you can see physician-specific results, center-level results, and VQI overall results. And then lastly, they'll have the comparative figure where they can see how their individual results compare to other physicians at their center. So they can see their results highlighted in orange and then compare that to other physicians. And then if their results differ significantly, if there's statistical significance, they'll have the little asterisks that you can see at the bottom there that indicates that their results are significantly different than their center as a whole. So that's an overview of the new physician reporting, and yep, hope everyone is enjoying it, and I'll turn it over to Carolyn now.
Katie, let's see if anybody has any questions, and
Okay, sure.
we can answer some questions now, and if questions come up later, you think of something, we can also address them at the end as well.
So we have our first question. It says, do the surgeons receive an email telling them there are reports available?
Yes, so the reports are sent out via the Pathways push reporting, and they'll get an email letting them know that there is a new report available in their share file of their Pathways account.
Is that it for now,
No,
Melissa?
we have,
Oh.
no, that was it for a minute. A couple more are loading. How often will these reports be sent out?
So these reports will be semi-annual around the same time as the spring and fall regional reports.
Okay. Can we request as data managers to see all MD information?
So the physician reports can only be uploaded to a physician pathways account. So in terms of viewing the individual physician reports, that will be determined by at your site access to different pathways accounts and the permissions there.
Okay, and then each center has to have 3 physicians doing procedures for a physician to get a report. Is that correct?
So that's what they need to have in order to appear in the comparative figure. If your center had, say, 2 physicians entered procedures, they would still get reports. They just would not appear. There would be essentially no comparative figure for your center, but they would see their individual results.
Okay, it doesn't appear anything's loaded, so I think that's all the questions for now.
Perfect. Thank you.
Thanks, Katie.
Yep.
So I just wanted to take the time before VQI at VAM to share with all of you some registry revisions that are going to be in production as of next Thursday. So the open aorta is going to have some minor revisions. We are continuing to fine tune the open aorta major revision. A number of variables have been retired. One of them being the ask of how much whole blood was given back to the patient. The next retired variable is the variable asking we ask if cardiopulmonary bypass was required during the procedure as a yes/no variable. That variable will stay. But in the current version, as of today, if you say yes to that, then you're asked 2 additional variables. One being heart bypass, was it partial versus full? That is going to be retired. And then the cannulation site required is also going to be retired. Within the long-term follow-up, there is a question that asks about hernia or flank bulges, and a none selection was never added. So now that will be added. And then 2 more retired fields will be the request to document proximal and distal zone of repair, and then the maximum aortic diameter will also be retired. So those are the revisions for open aorta. We wanted to share with everybody that the carotid artery stent interactive dashboard will be available and active as of May 29th. So that's great news. Thank you to our analytic team for working through some of the revisions that needed to be put in place for the dashboard. So within the infra and supra bypass registries, there is a new variable added. If within both registries you were asked what type of graft was used, was it a vein graft, or was it a prosthetic graft? If you chose prosthetic, in the current version as seen in the panel on the right-hand side, you were asked, is it Dacron, is it PTFE, non-autologous biologic, or other? There is a new type of tissue graft available on the market, and it is called acellular tissue graft. And it is a tissue engineered graft that is used to bypass the diseased vessel. And it was felt by our physician and surgeon champions that they wanted to have this select option within the registry so that you can compare outcomes of an acellular tissue graft to Dacron PTFE, or even this type of prosthetic graft compared to your venous grafts. We finally harmonized the antiplatelets across our arterial registries. I apologize about the image being slightly blurry, but because this isn't even in the playground, what we call mock-up yet. This was the cleanest image I could get. So within the antiplatelet medications, the physician champions really wanted to be able to identify which of the antiplatelet medications were P2Y12s and which were PAR1s. So that is why you will see P2Y12 clopidogrel, P2Y12 pasopril, and on down the list. So this will be harmonized across all of our arterial registries. We had to do yet another revision to the height and weight. Because we have now clearly defined within our inclusion-exclusion criteria that all ages are included, we needed to include the little ones in our height and weight min and max numbers. So that's all that is. These are randomly selected numbers. 6.6 pounds. The height seems a little wonky to you, probably 18.9 inches. Why did we come up with that? It's because centimeters within the registry does not include any additional digits beyond whole numbers. So we had to take that, the partial on the inches side. So for the CAD variable, this is one of the variables that has been identified using the data we have received from our source data audits as maybe a variable that would value having a little bit of education around it. So as you know, CAD is an acronym for coronary artery disease. This is a variable that is a common variable across all of our registries. It has been there for a number of years. It has changed slightly in that into 2023, CAD asymptomatic was added to all of the registries except for one of the carotid registries and the dialysis registry. Those two registries already had this variable, but we wanted to harmonize it. So with these definitions, none means that within the medical record, there is no documented history of coronary artery disease. There's no mention in the medical record or in any imaging. CAD asymptomatic. It is somewhere within the medical record that there was CAD documented either by imaging, clinical testing, but there is no history of MI and no current symptoms. So let's say a patient historically had a CABG, coronary artery bypass graft, or had some type of percutaneous coronary artery intervention, abbreviated PCI, had a stent placed in their LAD. That patient may be asymptomatic. We hope they are, but they still have the underlying history of CAD. And it's the same thing with transplants. You know, if a patient has a transplant, they get a new heart. Hopefully that heart stays healthy. It never develops any type of blockages, but the patient still has a history of coronary artery disease, which is what caused them to need to have a heart transplant. The next variable, history of MI or myocardial infarction with no symptoms. It is defined as a patient that has had a myocardial infarction or heart attack greater than 6 months ago, but is asymptomatic. Stable angina is stable pattern or symptoms with or without anti-anginal medication. MI less than 6 months ago is self-explanatory. The patient has had an MI from the time of procedure dating back 6 months. An unstable angina, which is the most significant, is any type of new onset angina angina of increasing frequency, angina that lasts more than 20 minutes, and or rest angina. These variables are in hierarchical order, so we ask that the select options of none through unstable angina are abstracted as the most severe. And you can see the down arrow indicating that unstable angina, according to the way the registry has been put together, is the most or the heaviest weighted variable. We're going to be adding a help text clarification, but I was asked to bring this to everybody's attention. We ask within the post-procedure within PVI and long-term follow-up if the target lesion experienced any type of thrombosis. There was clarification that needed to be added to the help text that for our P-tab cases or those cases using the detour device or even a homemade endovascular bypass, that the target lesion thrombosis refers to the P-tab device, not to the artery being bypassed. This is a big one that I think you guys, I hope, will find useful to you. This is, again, circling back to the carotid artery stent, CEA, hypo and hypertension, help text clarification. I received a question from a center, well, what if a patient is on vasoactive medications prophylactically? They never really had a hyper or hypotensive event. So Carolyn goes back and talks to the committees and got further clarification. This variable was abstracting the number of times a patient is treated for hypo or hypertension or both 1 hour after the end of surgery. And again, end of surgery is defined as the end of anesthesia or when the dressing was applied, whichever comes last. So any treatment perioperatively, which is during the procedure or surgery, up to 1 hour after the end of surgery, and not extending beyond that 1 hour mark to keep the blood pressure within the center-defined variables. If there was, and it didn't extend, you just abstract it as no. If the patient had hypo, hypertension, or both, it is abstracted when the treatment extends beyond 1 hour after the end of surgery, regardless if it was prophylactic or if they had a hypo, hypertension, or both event. And just I wanted to share some tips and tricks that came up. I've been getting a lot of questions from centers saying, well, this was an emergency and there's no documentation about the patient history or just a number of different things. Recognizing that not everybody has Epic, these images came from an Epic playground, but within a lot of the electronic medical records, there are places to find the current problem list, the significant history, the posts, the surgical history, as well as medications, whether it's the current medications or the medications the patient's on prior to admission. So hopefully this helps. I shared this with one of our providers and they were like, oh yeah, you're right. And this one provider, it was talking about an emergent carotid artery stent that was from a femoral approach. And we had a nice long conversation. It was a very good conversation. And I said, what, you went from the groin, you went up into the aortic arch, you imaged it. I said, so in your postoperative note, most people would put the type of arch in their post-op dictation. I said, and if you don't, you have a choice of just leaving it blank and not submitting the case at all, or leaving it blank and submitting the procedure without validation. Wanted to let you know that the next projected registry revision webinar is going to happen late July, early August. Within the webinar, we will be talking about revisions for smoking cessation that include your procedure form, the 30-day follow-up form, and long-term follow-up form. We're going to be adding some statin alternatives to the arterial registry data collection forms. There's going to be a TVAR registry revision. The EVAR-TVAR complex EVAR dashboards are going to be released. There will be over 100 help text revisions, and then we'll just do a quick highlight showing some of the highlights, or discussion, excuse me, talking about some of the highlights from VQI at VAM 2025. And with that, give me some questions.
Okay, so I'm combining a bunch of questions. How can people get a copy of this presentation after today's call?
The webinar slides and the recording will be on the members only side of vqi.org. Great question.
Yeah, so a couple people did that. So for the CAD variable, if the CAD is only noted on a stress test and the doctor states that, and the doctor does not state any findings in his note, the person's concerned that they're diagnosing the patient. So would they be able to use that? And I would think that if it's stated in the stress test, the doctor that reviewed the stress test would probably have noted the CAD. And that is a physician, but Carolyn, I'll let you answer that.
You know, these are the type of things, and I know it's hard to reach out to our physicians that are, and providers that are doing these procedures. But ultimately, you are so correct. You don't want to be diagnosing. There is documentation of coronary artery. Well, is it coronary? I don't know that you can diagnose coronary artery disease from a stress test. You can diagnose ischemia, and you can diagnose muscle injury. But what is that from? So from my perspective, and what I will probably, you probably should reach out to the provider and ask them.
So with the new graph material, will there be a selection to pick when the new drop-down option is available?
Yes.
Yes.
Yes, and that will be going out next, let's see, 29, May 29th.
Okay, one of this person's surgeons will not give the arch type for their TCARs, so they put not viewed.
And that's appropriate because for TCAR, you don't really visualize the arch. This is one of the things I have on our enhancement list, so that I'm going to try to reorder the variables within the data collection form, so that if it is identified as a TCAR patient, certain variables don't show up, specifically arch type. Great question.
So if you could go back to the hypertension slide, we have two questions that I think it will help to see. There's a question about the time frame. A clarification on hypotension. Is there a clarification stating hypo and hypertension treatment is limited to the 1 hour post procedure? Or is there a time frame coding this metric?
It is, oops,
Oh,
sorry
yeah.
about that. It is 1 hour after the end of surgery, with the end of surgery being defined as whenever anesthesia stops, or when the dressing applied whichever comes last.
Yeah, so and that time frame came from a study that is being presented, that a study that has long been published and has been validated multiple times, from Dr. Molass's group, and Dr. Molass and his team are presenting it during the carotid portion of VQI at BAM. It's a really great presentation. And here's a question about, can you go over the IV meds that you're looking for the hypertension to be assigned?
We do not list the vasoactive medications, but I don't hear, well, let me do this. This is the sheet, the actual sheet that it's probably pretty small for you guys, that I share with the development team. You can see the current help text. You can see the new help text. Let's see. We include for hypotension epinephrine, phenylephrine, norepinephrine, vasopressin, dobutamine, dopamine, millerone, isoperitol, and others. For hypertension, it is including but not limited to beta blockers, calcium channel blockers, ACE inhibitors, hydralazine, dopamine antagonist, alpha adrenergic blockers, nipride, nitroglycerin, and others.
So there is a question about an update that someone would like to be added to the amputation module. If you could please send that into Pathway Support. We keep track of all of those and they send them to us. And if we have documentation of the request, we can send it to the committees. So
Yes, thank you. Your timing is perfect because we are right in the middle of a major revision to the amputation registry. So I really appreciate your input and thoughtful suggestions.
So there's going to the revisions to the Open AAA has resulted in a payment adjustment from outside vendors. It's an increase. Currently, we do not have any data submissions while we work out the upcharge from the vendor. Wasn't sure if you were aware of this impact of changes such as this. We are aware, and the committee feels that the measures that were added were really important.
So,
Oh, go ahead. Sorry.
no. Just keep in mind the incidence of suprarenal. It's probably going to be there,
Yeah.
but the incidence of going into the chest, I don't know how often that's going to happen. And when you look at the data collection form, it's very daunting. You see a whole bunch, huge list of variables. But the thing that leadership has guided us on, and it is true, many of those variables are dependencies. So if you are only treating zones 8 and 9, all those branch variables, now I don't say all the branch variables because you still have your celiac, your SMA, and your bilateral renals. But a lot of the other stuff is not going to appear. The other reason why we had to do this is we are looking for a way, because we are a registry and real world based, to be able to compare real world outcomes. We are comparing endovascular treatment to open treatment, the number of reinterventions, the cost of the repair, how many times a patient gets readmitted. I mean, and we can't do that unless both registries were more similar.
So for CAS TCAR hypohypertension case post procedure, meds given 1 hour post are included. Is there a threshold for the ending time? So if a patient stays in the hospital multiple days, and they receive it like on day 4, would you still count that?
I'm thinking, give me a minute. I'm not. First of all, I hope it would never happen, but I think we still would have to
Assign it, yeah.
treat it. But what I would recommend is that in the comment box, hopefully this doesn't happen very often. Hopefully this is a hypothetical situation. But in the comment box, I would ask you to state that this happened on post-op day 4. And if there were any other things that happened, the patient might have had a big MI, the patient might have had a dysrhythmia, something other that might be tied to it. I do occasionally look at the comments in the comment boxes written in by our centers. And if we start seeing a number of these, then we'll have to take it back to the committee and see what their thoughts are. If they'll say, okay, and I'm making it up, anything after 3 days post-op is not included. What I would like to take back to the committee, though, and maybe even if any of you are at VQI at VAM, maybe this is a good venue to ask the panel and say, if there was another event, because on our post-op form, we have, say, did they have an MI? Did they have dysrhythmia? If you select any of those, maybe you still code that there was a hypertension event, but it's not included in the dashboard report.
And I think, not that I'm speaking for the committee, but listening to them discuss this variable, sometimes I think it was the intent of why they added this, I think, is sometimes missing. The research has shown if a patient receives this treatment, they are highly more likely to have an outcome, a negative outcome, some sort of event. So they added this as a kind of heads up. Hey, if you did this, they're probably going to have something else. It's a good indicator that something might be coming. And that's why it's added. Assigning this as a yes is not a negative thing. It's supposed to kind of be looked at as an indicator to something for the future. So I think sometimes it's the mindset on, we think if we assign it, we're saying they should not have had it, when actually it's being used as an indicator for something else. And someone else notated they had
Wait. I'm sorry.
Oh,
Before
yes,
we
go
go
ahead.
on, I
Yes.
have a comment to that. Now, within our data collection form, this variable is not included within the complication header. But on the dashboards, our quarterly dashboards, it is. So we are moving it out of the complication header in the dashboard and just reporting it as an outcome so that we can collect the data and still see what's going on. Now, I will share with you, I just attended a regional meeting, and there is a center that is doing a project on this very variable. Theirs is specifically around a TCAR procedure and the collection of and the treatment of hypotension. This particular center had a very high incidence of needing to treat their patients for hypotension greater than 1 hour after the procedure. They made some modifications to their patients, a little bit of a early recovery after surgery mentality. They told the patient to hydrate well the day before surgery. They had the patient stop their ACEs and ARBs, and then they hydrated the patient prior to the procedure using IV medication. And they have completely flipped their numbers. So what used to be a very high incidence for the need for vasopressive support post-TCAR is now below the VQI benchmark.
Yeah, it really is supposed to be a truly great indicator on patient outcomes. And I think that, I mean, I know that's why it was added. So I think when you think of it that way, you kind of want to include everything, because if they're having something later on, why are they having it later? But I mean, we would absolutely take stuff back to the committee. There's a question on including on discharge medications in the dashboard. I'm going to ask you to please submit that to 50 support, because like I said, we definitely receive those and can make changes, and it's really important to see how many people are asking for the same update to be made. Is it correct that there has to be more than one dose of med in an hour following the end of the procedure for CAS?
IV bolus, yes. That's what the definition says. Let me pull that over again. It's so small, and I apologize. This is just my worksheet. It specifically says the administration of a continuous IV infusion of a vasoactive medication for greater than 15 minutes of infusion time, or more than one dose of IV push or IV bolus required more than 1 hour after the end of surgery. So if you give just one IV push, IV bolus, you code no. But if you have to give more than one, and it's beyond the 1 hour end of surgery, then that would force you to have to code either yes to hypertension or yes to hypotension.
And then there's another question on that same point. So the med only needs to be given, the physician does not need to say that it is be given post-op for hyper or hypotension. And that is correct. That is correct.
Well, yeah, yes, if I would venture to say that if a physician is putting a patient on dopamine because of their kidneys,
Right.
that's not for the treatment of hypo or hypertension.
So someone else had a case where on day 4 they went into a hypertensive crisis, and they answered this question as yes. So I think that's correct.
It's correct with their current guidelines. So
Correct.
thank you.
Yeah. For IV hypohypertension meds, how do we abstract it when the meds are given due to a return to the OR episode for like a cabbage or a CEA or a chest washout?
I know what I want to say, but I have to go back to the committee and get confirmation from the committee. I can tell you with a lot of confidence that Melissa and I are working with the committee to add in cabbage, TAVR,
Yeah.
valve surgery, or any other type of major surgery during the same hospital admission and after a CEA, CAS. And there are a whole bunch of other things that we need to work around all of these additional surgeries that might happen at during the same hospital admission. But we will be taking that definitely back to the committee.
Yeah, it's a very, very good question. And then there's a question on how do you assign arch atherosclerosis for a case? Please send that to Pathways Support. And that's all the questions we have.
Well, I thank you, and I hope everybody is able to attend the VQI at VAM. And if not, know that the recordings will be available to those that have registered. but for those that weren't able to register, the recordings for VQI at BAM 2025 will be available late 2025, early 2026, so that you'll be able to see everything. And hopefully that'll help you. I hope this is helpful for everybody. I really appreciate all the input. I've been attending a lot of the regional data manager meetings to try and answer some of these questions. And I really appreciate all of your input. So thank you. And thank you for being patient with me. You aren't confrontational. You aren't combative. And I just really appreciate that. So thank you, because I think you all know it's not Melissa and I that are making these decisions. We're kind of the middleman. We're the provider of the information. So that's why I really encourage people to get up to the mic at VQI at BAM and ask these questions, because maybe our physician leadership isn't aware. I don't know. So thank you.
And many people are thanking you.
Oh, well, good. Good. I hope I'm helping. Thank you all. Take care.
Bye.
Bye.